log back in. The quiz is on benign gynecological disorders. Previous year NEET-PG recalls, INICET recalls, clinical-based questions, image-based questions. All of this has been added to the quiz. Okay, and we shall start in 1 minute. So good luck to everyone. So once I start, I can't stop. Okay, in between, I will be discussing a few questions. And all the questions are self-timed. Between 30 seconds to 1 minute, the faster you answer, the higher marks you get for those who are playing for the first time. Okay, so I think we'll start. I don't see anyone else joining, so let's start. Okay. Okay, a 28-year-old T1L1 comes with heavy menstrual bleeding. Which of the following is the least likely cause? 28-year-old woman. Least likely. If to enter, no one is answering. Quickly answer. Quickly answer. 7 seconds left, so everything is timed. You have to quickly answer. Okay, so this is a little tricky question. All of them can cause heavy menstrual bleeding. All right, IUCD can cause, fibroid can cause, PID can cause, even endometrial hyperplasia can cause. But look at the age. So in a 28-year-old woman, if you look at the causes of AUB, endometrial hyperplasia, pre-malignant and malignant conditions are lower down in the list as compared to if the same question was a 45-year-old lady, then you would definitely think of endometrial hyperplasia. So in AUB, always see the age that has been asked. All right, so let us see the scoreboard. 1 second. Okay, so this is the scoreboard. Kriti is on top, then Ridhima, Akash, Runanu Band, and then Avinash. All right, next question. 30-year-old woman underwent a diagnostic hysteroscopy for HMB, heavy menstrual bleeding. This image is seen. What is the diagnosis? So answer quickly. The quicker you answer, the higher you are on the scoreboard. Yes, this is a submucous fibroid because it is inside the endometrial cavity. So so you can see this is the hysteroscopy. This is how a submucous fibroid appears. An intramural fibroid, you may see an indentation in the cavity, but otherwise it is in the myometrium. And a subserosal fibroid won't be seen on hysteroscopy. It is lying outside the uterus or on the uterine serosa. Okay, so let's see the scoreboard. Does it change? Okay, Ridhima's on top, Kriti, sarcoidosis, and then the rest. Okay, so now you've got a picture of how to play this game. Okay, so the scoreboard can change pretty quick. Okay, next question. Question number 3. 45-year-old with HMP for 3 months. Ultrasound shows a 2 centimeter fibroid. What is the next best step? This is a previous year recall. Will you do a myomectomy, a hysterectomy, an endometrial biopsy, or will you put in a Mirena? 45-year-old lady with HMB for 3 months. Ultrasound shows a 2 centimeter fibroid. What is the next best step? Okay, so most of you didn't get this right. So what will you do? See, 45-year-old with HMB and there's a small fibroid. Okay, so before jumping to the conclusion that the fibroid could be the cause of the HMB, the lady is 45-year-old. Please remember, whenever there are fibroids are a hyperestrogenic state. So fibroids are usually associated with other hyperestrogenic states. And in this age group, you have to look for endometrial hyperplasia and endometrial malignancy. So before doing a hysterectomy, you always have to do an endometrial biopsy. Please remember this point. Okay, because you may have a hidden endometrial cancer growing inside this patient. So if you're doing a hysterectomy, your treatment may be incomplete. So always a lady in the perimenopausal age group who comes with abnormal uterine bleeding, always do an endometrial biopsy. All right, to rule out pre-malignant and malignant conditions of the uterus. So fibroid is a hyperestrogenic state condition. Others are endometrial hyperplasia, endometrial cancer, and even endometriosis is associated with hyperestrogenism. Okay, so let's see who got this right. Okay, so Ranuban got this right, then Ridhima, Kriti, sarcoidosis, and Shiveha. All right. Okay, next question. A 34-year-old with menorrhagia is diagnosed to have a submucosal fibroid with less than 50% protrusion in the endometrial cavity. She is FIGO type what? This is also previous year recall. She type 0, type 1, type 2, type 3. Less than 50% protrusion in the endometrial cavity. Yes, she's type 2. So type 0 is when the entire, like the picture I showed you previously was type 0. The entire fibroid is lying inside the cavity, or it is a pedunculated fibroid. Type 1 is when there is more than 50% lying in the cavity, and type 2 is when there's less than 50% in the cavity. That means the majority of the fibroid would be intramural rather than submucosal. So this is type 2. This is also a previous year recall. All right. So slight change. AK Avinash, they've entered the scoreboard. Okay. Next question. 36-year-old lady with swelling and pain in the vulva. On examination, this is seen. What is the best management? Okay. Slightly tweaked it a bit from previous years. Will you do an IND, a marsupialization, an excision, or a mag sulf dressing? 36-year-old lady with pain, and this is the swelling seen. What will you do? Yes, so I'm sure most of you know the diagnosis. The diagnosis would be a Bartholin cyst, and the treatment of choice of a Bartholin cyst is marsupialization. That means we give an incision on the mucosal edge of the Bartholin cyst, and then we evacuate whatever's inside, and then we suture the edges of the incision onto the vaginal mucosa. That is called a marsupialization. So this is the treatment of choice for a Bartholin's cyst. Okay. Okay, so Kriti is back into the scoreboard, and first position remains the same. Okay, next question. A 34-year-old gravida 2 with a known fibroid presents at 16 weeks with severe abdominal pain. Her total count is 15,000. What is the best management? So she's pregnant, 16 weeks with a fibroid. How will you manage her? Please excuse the spelling mistakes. Yes. So what is the diagnosis? It is red degeneration of fibroid. This is also a previous year question. Okay. And for red degeneration, we don't have to do anything much. We just give analgesia, rest, and hydrate her well, and that will sort out the issue. So Ridhima is on top now. Otherwise, the top 5 remain the same. Next question. The most common degeneration seen in fibroids is quick. One word answer. Cystic, fatty, hyaline, red. Okay, so everybody answered correctly. I'm very happy. Okay, good. Scoreboard remains the same. Okay, next question. 23-year-old with HMB, heavy menstrual bleeding, is diagnosed to have fibroids. She's curious to know why fibroids cause heavy bleeding, which is incorrect. Okay, so endometrial ulceration, all the rest do cause increased uterine bleeding. How? Because of increased vascularity, increased surface area, and there is dysfunctional uterine contractility. Okay, endometrial ulceration is not seen. If at all, there's a submucous fibroid, then the surface of the fibroid can get ulcerated, not the endometrium. All right, so this is the fifth question, the fifth answer, the fourth answer is incorrect. All right. So let's see, does this change? Slight change in positions. Okay. AK has a streak with 5 correct answers in a row. All right, next question. Which is not an indication for medical management of fibroid uterus? Which is not an indication. Right, correct. Most of you got this. So any woman with infertility who has a submucosal fibroid becomes a direct indication for removal of that fibroid. You have to do a hysteroscopic myomectomy for any lady who has come with infertility and has a submucosal fibroid. Okay, can't see the question. Sorry, I just saw this iPhone. I hope you can see it now. The question comes in the beginning and then at the top. Okay, I hope that's cleared out. I didn't see that in the beginning. Okay. So a submucosal fibroid with infertility, you will not give her medical management. For all the rest, for pre-op shrinkage of the tumor, for pre-op correction of anemia, or for a perimenopausal woman who you may think that post-menopause, the fibroid may shrink in size. For all those, medical management is indicated. Okay. Okay. So slight change in positions again. AK has 6 correct in a row. Congratulations, AK. Okay. Next question. 32-year-old with acute abdomen and vomiting. On examination, tenderness is present. Ultrasound shows an ovarian cyst. Laparoscopy is done, which is incorrect. Which is incorrect. Yes. Okay. So most of you got this right. So Doppler is the diagnosis of choice if you have a patient with suspected torsion. So what was the picture here? You can see you can see the tube and the ovary are twisted. So this is torsion. Okay. This image is typically showing torsion and this is the ovarian cyst. And what do you do? You have to detort and the twisting, you have to untwist whatever's twisted and do a ovarian cystectomy. If it is delayed, if you don't operate, the patient may end up losing up the ovary. You may have to do an ovarectomy if it is infarcted. And dermoid is very commonly associated with torsion. But what is important to remember is it is diagnosed best by Doppler. Doppler will show if there is absence of flow. If there's absence of flow to that ovary, that means the blood supply is cut off, and hence Doppler is used for diagnosing torsion. All right, apart from the symptoms, of course. Does this change the scoreboard? Okay, Kriti is back in the game. Sarcoidosis is number 1. Shiveha, AK, Ridhima. All right. So AK again, highest streak of 7 in a row. Next question, number 11. 46-year-old underwent a laparoscopic hysterectomy for AUB. This is the uterus after hysterectomy. What is the diagnosis? Again, previous year recall. What is the diagnosis? Is it adenomyosis, endometrial hyperplasia, endometrial cancer, or a fibroid? Yes, most of you got this right. So those of you written fibroid, you will see it very well defined. Okay. And you saw those reddish lesions here. Okay, you can see the uterus is uniformly enlarged, which is a feature of adenomyosis. You can see these red lesions in between. These are typical of adenomyosis. Okay, in fibroid, you will see a nicely well circumscribed lesion somewhere, say here or here. The whole uterus won't be enlarged like this. All right, so this is adenomyosis. So, yeah, scoreboard, slight change. AK again. Okay, someone needs to break the streak of AK. Next question. Dysmenorrhea, infertility, irregular menstruation, and vaginal discharge, which are seen in endometriosis. You have to select the option. This is previous year INICET, July 2021 INICET question. Right, A and B. Okay, so if you talk about endometriosis, remember 5 Ds of endometriosis. What are the 5 Ds of endometriosis? The first is dysmenorrhea, which is progressive and severe. That means it keeps increasing with every cycle. the duration, and the severity. Second is dyspareunia, which is not mentioned here. Third is dysfertility. So in place of infertility, to remember, you can remember it as dysfertility. So dysmenorrhea, dyspareunia, dysfertility, dysgeusia, that means painful defecation. And the fourth is disordered menstruation. Okay, now I know C choice is given here as irregular menstruation. That's why many of you have marked A and C. But when I say disordered menstruation, endometriosis usually presents as regular cycles, not irregular. It will present as menorrhagia, not as irregular cycles. So amongst these four options, even in the exam, when it was asked in NICT, these were the options given. Okay, so if the ideal option maybe should have been A, B, and C, because endometriosis in some women can cause irregularity, but the most common features are dysmenorrhea and infertility. So if given a choice, A and B is a better choice to mark. Okay, and more than irregular menstruation, it's actually regular menstruation, but heavy flow. So endometriosis can cause excessive or heavy menstrual bleeding, and then dysgeusia and dyspareunia. So these are the 5 Ds of um, um, endometriosis. You can also add to this dull aching abdominal pain. Okay, so these are the Ds of endometriosis which need to be remembered. Okay, no change. Okay, all right. Next question, number 13. 32-year-old parrot who living through with dull aching abdominal pain. LMP was 3 weeks ago. Ultrasound shows a 5 centimeter simple cyst in the right ovary. What is the next best management? So this also is previous year NEET-PG 2021 question. 32-year-old with pain, LMP 3 weeks ago. Ultrasound shows a 5 centimeter simple cyst in the ovary. What will you do next? Yes, you won't do a CA-125 or a diagnostic laparoscopy or a CT scan because the features are of, she's young and it says a simple cyst. So whenever simple cyst is mentioned and the size is less than 6 centimeters and she's relatively asymptomatic or only with minimal symptoms, then she doesn't require anything further to be done. If she comes with acute abdomen, you have to operate. Okay, then a diagnostic laparoscopy or laparotomy will come into picture. Okay, if you are worried about malignant features, okay, say ascites was there, or say bilateral, or say thick septa were there, or papillary projections were seen on ultrasound, then you would order a CT scan and a CA-125. If nothing is there, you can do a follow-up after 3 months, plus minus give her suppression. So suppression means most of these simple cysts are follicular cysts. So you can give OC pills for suppression, or you can simply follow up after 3 months. Both the answers are correct. Of course, OC pills wasn't mentioned here. These were the options given. So the best option is follow up after 3 months. Okay, this is previous year NEET-PG question. Okay, change in scoreboard, slight change in scoreboard. Okay, Kriti and Ridhima move up and AK is still on a streak. Next question. 34-year-old Paravan is planned for myomectomy for a large symptomatic fibroid, which is not an intra-op step in reducing blood loss. Which will you not do to reduce the blood loss in the myomectomy? Okay, most of you got this wrong. Okay, so you can do a bilateral uterine artery ligation that in fact may help in reducing the blood loss. But what you won't do is you won't ligate the vessels over the surface of the myoma. That won't help in significantly reducing the blood loss. Bonnie's clamp, yes, you will put. You can ligate. The many people ligate. In fact, it is recommended ligation of the temporary or permanent ligation of the uterine artery bilaterally, and use of vasopressin before giving your incision. But ligation of vessels are, they're just superficial vessels. They won't help much in reducing the blood loss. Okay, so this may or may not change the scoreboard. Okay, Kriti moves up. So Kriti has the highest streak of 6. All right, next question. Number 15, which is incorrect regarding the use of GnRH agonist therapy in fibroid uterus. Which is incorrect, which is false. Yes, they do lead to a reduction in the size. Okay, around 30 to 60% reduction is seen after 3 to 6 months of use, and they're primarily used for reducing the size pre-op. If it's very big in size, then we give it pre-op to reduce the size. It is used for a limited time period, otherwise it causes loss of bone mineral density. And that's why if we're giving it for a longer time, we usually add back therapy with OC pills. And the high cost obviously is a disadvantage. So the incorrect answer is it doesn't cause a reduction in size, because it does. Okay, so AK is leading now, followed by sarcoidosis, Ridhima, Kriti, and Shiveha. Okay, next question. Question number, I think 16. How best will you differentiate a uterine mass from an ovarian mass on clinical examination? Okay, I'll give it a 60 seconds for this, so carefully answer this. How best will you differentiate a uterine mass from an ovarian mass on clinical examination? Okay, so I knew this would be confusing. Okay, so whenever we have a patient with an ovarian mass and a uterine mass, okay, or a mass per abdomen, a gynecological mass per abdomen, the two things which are important are in a uterine mass, you will not be able to palpate the lower border, okay, because it's a pelvic organ. Ovarian mass, most of the time, you will be able to appreciate the lower border, okay. Transmitted mobility, what happens? What is transmitted mobility? It is done on bimanual examination. You're doing a vaginal examination and one hand is on the abdomen. So with one hand on the abdomen, you move the abdominal mass. If the cervix moves, your other hand will feel the movement of the cervix. That means the mass is arising from the uterus. Okay. So if it's an ovarian mass and you move the ovarian mass, the cervix will not move. That is called a transmitted mobility. So transmitted mobility will be absent in an ovarian mass. It will be present in a uterine mass. Okay, and the lower border will be felt in an ovarian mass. Of course, there are exceptions to this, but this is the general rule. Exceptions would include if there are adhesions between the ovary and the uterus, and on moving the ovary, the uterus will also move. That is one exception. Okay. So, and in a malignant ovarian mass, you may not get the lower border. Okay. So there are exceptions to the rule, but generally, transparent mobility, please remember, is absent in an ovarian mass. It is present. What is it? On moving the mass, if the cervix moves, that is called transmitted mobility. And the lower pole will be felt in an ovarian mass, not in a uterine mass. Okay. Slight change. Ridhima is on top. Okay. Number 17. Meek syndrome is what? Easy question. I think this is. Yeah, everyone's got this. Most of you have got this. So ovarian fibroma plus ascites plus pleural effusion is Meeks. Pseudo Meeks is the same thing, ascites plus pleural effusion plus something other than an ovarian fibroma, maybe a leiomyoma or a struma ovary or something else. But if it is seen with a fibroma, the ascites and pleural effusion, and very important, on removing the fibroma, the ascites and pleural effusion settle down, then it is called as Meeks syndrome. Okay. This came in the FMG exam. That's why I put this. Okay, so AK still on top. Oh, sorry, AK on top. Rhythm has gone to number 2. Next question. A 40-year-old woman complains of a swelling in the vagina. On examination, the swelling was arising from the anterolateral vaginal wall. What is your diagnosis? Anterolateral vaginal wall. That is the clue. This is the image. This is a Gartner cyst. Most of you got this right. Why is it not a prolapse for whoever marked prolapse? Because you can't see the cervix. If it was a prolapse, uterine prolapse, I'm not talking about a cystocele. Cystocele would have been anterior, not anterolateral, first of all. Prolapse, you would have seen the cervix. If it was uterine prolapse, the cervix should have been seen. It was not seen in that image. All right. So yes, this is a Gartner cyst arising from the Gartner's duct. Characteristically, remember, it is arises from the anterolateral vaginal wall. So if you see anterolateral vaginal wall mentioned anywhere, it is straight away a Gardner's cyst. Okay. Slight change in positions. Okay. Last three questions. 25-year-old woman with acute abdomen is diagnosed to have a dermoid. This is the laparoscopic image, which is incorrect. And I think we discussed this in the group also. Slightly, I changed this. Okay. So dermoid cysts, please remember in the group also, I stressed on this point, dermoid cysts have a lot of fatty and sebaceous material. So because of that, they're very light weighted and they float in the peritoneal cavity. So if something is floating, they are prone to torsion. And also when we do a bimanual exam, they are the kind of cysts which are characteristically felt anteriorly. So if you feel a cyst in the anterior fornix, that means it is a dermoid. Okay, normally when we feel an ovarian cyst, we'll feel it in the lateral or the posterior fornix because of the weight they go down, or they are laterally because they're in the adnexa. But dermoids characteristically float up. So you will palpate it characteristically in the anterior fornix when you do a bimanual exam. Please remember this. Less than 1% are malignant. Okay, mature teratoma less or dermoid cyst less than 1% are malignant. 10% are bilateral. Okay, so remember these points. Dermoid cyst commonly gets asked in the exam. You will have a specimen showing teeth and hair and sebaceous material. That has been asked previously. I didn't put that image because that is a very obvious image. Okay, so I twisted the question a bit. And they're very prone for torsion because they are anterior, so they undergo torsion. Okay, and what is the treatment of torsion? We discussed that we untwist and then we do a ovarian cystectomy. Okay. Any change? Okay, slight change in positions, but the top five remain the top five. AK, Ridhima, Shiveya, sarcoidosis, and Kriti. Last two questions. A 34-year-old with infertility has two intramural fibroids, 5 centimeter and 6 centimeter, distorting the cavity. What is the next best management? Will you do a lap myomectomy, an IVF, a HIFU, or a uterine artery embolization? This is again previous year NEET-PG 2021 question. Slight change. Yes, I'm glad everybody got this right. So that means you understand. So if a woman has infertility and fibroid, when will you do a lap myomectomy? Only in two types of fibroid. One is a submucosal fibroid, any size, you will remove it. If she's infertility with a submucosal fibroid, that means a fibroid in the cavity, you will remove it. If she's infertility with an intramural fibroid, then you will remove them in two circumstances. One, if it is distorting the cavity, and number two, if it is very large, more than 5 centimeter, and in some cases, if it is causing a cornwall block, okay, which was asked in the last EPG. Okay, in there it was given 5 centimeter, 7 centimeter, and blocking the cornua. Then also you will remove it. So submucosal fibroid any size, intramural fibroid more than 5 centimeter, cornu causing blocking the cornua, and if it is distorting the endometrial cavity, then they need to be removed. Subserosal fibroids do not need to be removed for infertility as such. Okay, so please remember these points about fibroids and infertility. Okay, slight shift in positions, and last question will determine the winner. Okay, number 21. 35-year-old with intermenstrual bleeding, hysteroscopy, the following is seen. What is the next best management? This is seen. We do a hysterectomy and endometrial ablation, hysteroscopic polypectomy, or laparoscopic myomectomy. Yes. Okay. So all of you got this right. This is an endometrial polyp. all my intelligent kids. So this is a previous year AIMS question. What will you do? You'll do a hysteroscopic polypectomy. Okay, this is not a fibroid, and even if it was a submucosal fibroid, the answer would have been hysteroscopic myomectomy. For anything submucosal, the answer is hysteroscopic. You will not do a laparoscopy for something which is approachable by a hysteroscope. Okay, hysterectomy not an option right now. Okay, she may require it later on if the bleeding doesn't settle. Endometrial ablation also not done. If there is a clear-cut polyp, then endometrial ablation won't help. Just remove the polyp is what is going to help her. Okay, so let's see the final scoreboard. So on the podium, number 3 is sarcoidosis. Congratulations. Number 2 is Shiveha. Congratulations. And number 1 is AK. So congratulations to all 3 of you. And runners are Pridima and Kriti. Congratulations. So I hope you all had fun. If you liked playing this, please tell your friends. We do this almost every week or at least every 10 days. I think we're able to do one quiz. Okay, I told you the topics that are pending. We will do those also. Okay, so iPhone says thank you. Thank you guys, and please forgive me for any glitches or any this thing. I try to make sure everything is run smoothly, but sometimes we can't help technical issues. So next quiz, I will inform you on the group. Okay, but thanks for joining. Thanks for playing. Thanks, Kriti. Okay, bye. Good night.